Thank you. So my name is Maria Pons-Vizcarra, and I'm an innovation project manager at AQuAS. And at AQuAS, we are the agency for health, for quality and health evaluation in Catalonia. And we are also the coordinators of the RaDAR project. As Giovanna also explained, RaDAR is an European project co-funded by the COSME program. And RaDAR stands for Rapid Detection and Control System for Antimicrobial Resistance. And as the name indicates, the objectives, the main aim is to address the urgent need of rapid detection and effective infection control systems for AMR. And we are doing this through the implementation of a value-based, cross-border, collaborative procurement of innovative solutions, so a PPI. So I will give you now an overview of the project and the methodology that we used. But first, I want to go back a few years ago, because RaDAR comes from another project that was a PCP project that was called Anti-Superbugs. Anti-Superbugs was a PCP that started in 2016 and finished in 2022. And in which AQuAS also participated as the lead procurer for several buyers that were from Spain, from Catalonia, Italy, Germany, and UK, and some also supporting entities. And Anti-Superbugs had the challenge of finding a way to rapid detect microorganism and its resistance mechanism, because without that, we were not delivering appropriate treatment or appropriate antibiotic. So the idea was to have a surveillance and infection control system based on prevention, reporting, and prompt intervention. So that's where RaDAR comes from. So from this PCP, we move to the RaDAR-PPI. So now I'm going to give you a bit of an overview of the RaDAR-PPI consortium and the RaDAR project. RaDAR started, as Giovanna also said, in January 2022, and will end now in the next month, in June 2026. RaDAR had a total budget of 4.3 million euros, with a contribution from the European Commission of 2.5 million. And RaDAR is a consortium of 11 partners, from which 5 of them are public buyers. So we have 5 public buyers from Italy, France, and Spain. Those buyers, as Rosanna also introduced them a bit, are RESA, that is a central purchasing body in France, which had a procurement budget of 900,000 euros, and the procurement was divided in 10 lots. Then we also have Institut Català d'Oncologia, ICO. It's an oncology institute or oncology hospital in Catalonia, close to Barcelona. And they had a budget of 800,000 euros, and the procurement was divided in 3 lots. Then we have also the University of Naples Federico II, the public health department. We also call it UNINA, in Italy, in Naples, and they had a procurement budget of 150,000, and they did one procurement not divided with lots. Then we have Laboratorio de Referència de Catalunya, that is a reference laboratory, with a procurement of 200,000 that was divided in 3 lots. And the last buyer is BioGipuzkoa, that is a health research institute that had a procurement of 100,000 and also not divided in lots. And then we have 6 supporting entities. Among the supporting entities, AQuAS, the entity that I represent, that we are also the coordinators. Then we have also INSERM, from France, that are also the coordinators of another program that is a joint action called JAMRAI. Then we have INSME, that is from Italy, and is helping us with the communication of the project. So also many thanks for the help on organizing this event and all the dissemination. Then JERA, that is from UK, that they are experts in public procurement. Consorci de Salut i Social de Catalunya, that is a Catalan GPO, and Hospital del Mar. And Hospital del Mar is doing the procurement together with the Laboratori de Referència, also in Barcelona. They are a general hospital. So from here, let's move to the methodology used. So at AQuAS and also in other innovation projects that we did, we follow a step-by-step approach, starting with the needs identification, the needs assessment. So first, we identified what is the problem and the needs that we have, and we verify those needs, we prioritize the requirements, and we build a business case. From this first step, we move to the market assessment, the innovator's readiness and feasibility to solve that problem, the needs that we have. And for this, we do a state-of-the-art and horizon scanning and also market consultations. So with this, we know if the market is ready to provide a solution for the needs identified, and if the solutions available are mature enough to solve the problem. Then we move to the adopter's feasibility, so the buyer's feasibility. And here we identify which procurement are we going to do. In the case of RaDAR, with the public procurement of innovation, among other options that there are available. And we do this having clear the reimbursement schemas, so also agreeing on risk-sharing mechanisms and payment for results. But this is not a step-by-step approach that we follow one after another, but it's an iterative process, and some of the steps overlap also. And that is important because we are not doing the first one without taking into account also what would be the reimbursement schemas, for instance. So this is the methodology that we also followed at RaDAR, but actually we went one step further. That is that we did a coordinated cross-border procurement, because the procurement was coordinated among the different buyers, and also cross-border because the buyers are from different countries. So we had this common preparatory phase in which buyers and all the partners from RaDAR work together to define first the clinical demand, and then also the market readiness assessment with several market consultations. From this common preparatory phase, we move to the publication of the tenders, and each buyer published its individual tender per locality, and also each of them execute their tenders individually, but this execution was monitored in a coordinated manner. So let's now go kind of a bit step over step, the process that we follow at RaDAR. So first of all, what's the problem? Rosanna also talked a bit on her introduction about the problem. So in 2019, there were about 5 million people that died from illnesses in which AMR played a role. And from those, 1.3 million were as a direct result of AMR. So if things continue as they are, or they were in 2019, there will be more deaths than cancer by 2050. So this also supposes a high economic burden, 1.5 billion euros annually in healthcare cost and productivity losses in the EU. So we can say that the manner in which we treat infections now will endanger our health in the future. So then RaDAR also had the need to respond to the Joint Action on Antimicrobial Resistance and the EU Action Plan, in which we had the aims to improve early detection systems to ensure quality care process, screen drug resistance and virulence to improve treatment effectiveness, reduce both healthcare and governmental costs, and also report and rapid communication to increase system resilience. And we had a good example of how important this is from the COVID-19 pandemic. So from here, and knowing what are the needs, we followed a multi-layer approach to understand the AMR context of each buyer group. This needs identification and clinical demand definition was led by ICO, Institut Català d'Oncologia, this multi-layer approach went from analyzing the macro level of each of the buyers, so the global context policies and objectives of each institution regarding their national guidelines, actual plans, policies, etc. So more in the macro level. Then we move to the meso level. So which agencies are in charge of AMR strategies, the levels at which AMR protocols are implemented, so the strategies that are taking place, etc. And from this, we move to the micro level. So the processes, workflows, methodologies, the tools used, and professionals involved in the management of AMR at each of the healthcare institutions. So for instance, this is the workflow before the RaDAR implementation. So we established which one was the workflow from suspicion of infection till treatment and patient follow-up. And from this process, from this workflow, we identified all the points in which we would like improvement, the common pains that we had from this process. And I will not list all of them, but for instance, lack of screening facilities, complex sample extraction, slow diagnostic tests. There were also difficulties for communications between the important stakeholders, difficulties for key patient data visualization. So from those needs and those pains identified, we move to the definition of the clinical demand, and that also followed a process. So first, from all the needs identified, we prioritized the needs, and we did that using semi-structured questionnaires that were completed by healthcare professionals from all the institutions from the RaDAR project. From the needs that were prioritized, we also validated and discussed those needs with experts. So both internal experts from the RaDAR, but also external experts took part of focus groups and interviews to help define the clinical demand. We also did an inventory of pathogens and multi-resistance detection systems, and we took the input from the business case that each buyer did, and and the market readiness assessment to define the final clinical demand. So in parallel, because it was not one after another, but were done in parallel, we also did the market consultation, and this was done in 4 different steps. First, with the early notification to the market. We wanted to make the market aware that the tenders were coming early enough so that the market would be prepared. So we did this notification at the beginning of the project. So quite before in advance, the actual tenders were going to be published. But the market then was aware. Then we did the market sounding. So we would have a discussion with the companies. The companies could say what they had available, etc. And then we moved to the market consultation events. And we did 5 consultation events. 4 that were local, 1 per locality of the buyers, and 1 international one that was online. And then after those market consultations, we also did bilateral meetings with suppliers. So the buyers met individually with the different suppliers interested to know what was available. So some results from the market participation. As I said, we did 5 market consultations. More than 160 participants we had in the market consultations events. From those, more than 50% participated in in the market sounding. We did then 48 bilateral meetings with suppliers, and from those 48% were SMEs that participated in those meetings, and the participants were from 12 different countries. So now let's move on the methodology that we used for building the call for tenders. And we use the theory of change methodology. And this methodology follows a reverse engineering logic. So we start from the end. So what is the long-term result that we want to achieve? What is the impact that we want to achieve? From there, we move to the outcomes, so the midterm results that are needed to achieve the impact. And from there to the outputs, so the short-term results needed to achieve the outcomes and the impact. And in order to assess those results that we want to achieve, we involve all the stakeholders, including patients and citizens, healthcare professionals, the healthcare providers, the health system, the more general socioeconomical and environmental impact. And then with this methodology, we could assess what is the impact that we wanted to achieve with RaDAR, that is to having an infection prevention control system and an appropriate treatment. And for this, we wanted to improve how AMR is managed in 4 different sectors: patient, pathogen, sample, and prescription. So we wanted to improve those 4, so patient, pathogen, prescription, and sample management. And the short-term results were that we wanted to improve the way that the healthcare professionals were able to visualize the data and to support, to have support for pathogen and on-site management. So from those results, we could then define all the activities that were necessary to achieve them. In the case of RaDAR, here are all the different activities, but are grouped in 4 categories that are MDRO detection, training and support, information access, visualization, and data aggregation, and the last one that is interoperability. So from those all those activities, each buyer selected the ones that were that they were more interesting because of the needs that they have, but also the budget that they have available, the risk that they wanted to take, and the specificities of each institution. Because as I mentioned before, we had a quite broad, quite different types of institutions. So depending on that, each of them selected the activities that were more important for them, and also taking into account the other specifications. What is also important is that we want to generate an evidence. We want that those contracts are permeable to value. So by using the theory of change, aligning it or having the inputs from all the stakeholders, aligning all the activities with the different professionals involved. From the activities selected, we build the call for tenders by taking those activities and transferring them as requirements for the call for tenders, linked to a specific KPIs to measure those results, and to be monitored, to evaluation elements, and always having a clear payment methodology also. From this framework, each of the buyers, and also taking into account their specifications, each of the buyers published its own tender. So we had 5 tenders published, 1 per buyer, but always taking into account that we want to generate an impact that is the same. So we have the same final result that we want to achieve. And for that, and in order to evaluate those aspects, we also had the common KPIs, a bit different from, depending on the specificities of each buyer, but common KPIs to evaluate the evidence that we generated during the intervention. And the results included reduce the transmission, reduce the nosocomial infections, and also reduce the length of stay. So from here, so each buyer published its own tender. There were 18 contracts awarded to 15 different companies. I'm not going to enter in detail on the results of that, because each of the buyers will now explain exactly what. Sorry, always moving alone. Each buyer will explain the procurement that they did and the results that they have. So I just want to give you some details on how we did the monitoring and evaluation. So after the contract signature, there was a kickoff meeting, and also the governance of the contract was reviewed. And then there was the implementation phase, and the implementation phase was divided in 3 steps. First, the change management, in which there was the first process of adjustment of the service provision, so like changing, right, that workflow that we saw at the beginning to the workflow that would be now with the new solutions, training the professionals. And this phase ended when the solution was integrated and ready, and we also had a report from that part. And then we started with the deployment phase, in which the solution was up and running. And in those deployment, we had the periodic collection of the results obtained, KPI calculation, and at the end of the first deployment phase, we asked for an interim outcome report, so the first results. And at the end of the project, at the end of the deployment phase, we had also the evidence that we generate, and also an end of the project report to know exactly all the results achieved by the project. And during all the implementation phase, we also compile the lessons learned, both from the buyers and also the economical operators, because we want that the next time that we need to do something similar, we can do it better. So we are gathering all this information to be able to apply it in future procurements. So now, some of general outputs from the RaDAR project. All the results information is published in the website, so if you have any doubt, question, I'm happy to also answer the questions, but you have all the information on the website. Rosanna also mentioned, so I will not go into details, some of the deliverables that were public, that were published recently, as the handbook and the One Health approach to tackle AMR through PPI. Those will be discussed also briefly this afternoon with presentations from Rosanna and Luis. We also have a report from the market sounding and the market summary that was from when we did the market consultation. At the YouTube channel, we have all the videos also from the presentations we did, etc. So if you have any question, you can review that. But I wanted to highlight that we did a series of animated cartoons that we call the RaDAR collaboration series, in which we explain a PPI adventure against AMR. So it's a series of videos explaining how we did PPI in a more divulgative way, which I think they come out quite nice to first understand what is PPI and what we did. And also on the Zenodo community from the RaDAR project, we have all the information available there that will also last forever, hopefully. With that, I wanted to thank first the whole RaDAR consortium for all the work in those 4.5 years. We work hard, but I think we also have very nice results. And I also want to thank you for your attention and for coming here to the final event.